would like to welcome you back in our webinar series provided by the Saudi Association of Neurosurgery, SANS Academy. Today we have Dr. Abdurrahman Alturki. He's a consultant in King Fahd Medical City. He's a vascular neurosurgeon, endovascular neurosurgery, and a neurocritical care. He's a section head of neurocritical care in National Neuroscience Institute in King Fahd Medical City. Thank you very much, Dr. Abdurrahman, for your time and participation with our academic series.
Thank you very much, Ahmed. Assalamu alaikum. كل سنة وانتم طيبين جميعا. Good evening, ladies and gentlemen. Thank you very much. I would like to thank the organizing committee for giving me this opportunity to present about a dear topic to myself, vasospasm and subarachnoid hemorrhage. Today we're gonna tackle it from a different angle. We'll try to have some time to unify our prospects with regards to definition, management, diagnosis, and pathogenesis. When I look to aneurysmal subarachnoid hemorrhage, it's a monster. It's a bad disease. It's one of the most challenging diseases that any neurosurgeon, any intensivist can face. From an ICU standpoint, it is the ultimate disease, if I can say that you can treat. It has an effect not only on the nervous system, but almost every organ in the body. And the best example really I found is this imaginary monster that I will ask you to name it. You can post its name in the chat. When it's a mythical creature that has 7 heads, and every time you chop a head, you think you killed the monster, it regrows again, and so on and so forth. So this is you here, this is the neurointensivist, this is the neurologist, this is the radiologist. You're trying to tackle this beast. You think that you kill the monster by eliminating basically the source of the bleeding, which is the aneurysm, and then other problems acutely pops in. This is all happens within the first week, and we're talking about only neurological complications. You can add a long list of systematic problems. So it's a bad manifestation of a bad disease that we really need to have a common understanding in diagnosis, and hopefully once we have a shared understanding about defining this problem, then we can treat it hopefully together. So in this presentation, I will discuss and try to unify definitions from the literature, and then I will go through understanding a little bit of pathophysiology. There are textbooks trying to explain this, and then we'll try to unify the approaches to diagnosis for vasospasm, and finally we'll touch a little bit on the management, and hopefully we will have an agreement on the best way to manage these patients. We all know that vasospasm is an important complication of subarachnoid hemorrhage. The problem is you cannot tackle the problem if you don't have specific diagnosis. If you read through the literature, you will find commonly 4 definitions, which I'm going to mention here. You will see people saying it's symptomatic vasospasm, which is clinical deterioration deemed secondary to vasospasm after ruling out all other causes. The second definition, which I think is the most representative and the most important nowadays, is delayed cerebral ischemia, which is symptomatic vasospasm or infarction on CT attributed to vasospasm. So you see there is the radiological touch in this definition. And then the last 2 are radiological definitions, angiographic vasospasm and transcranial Doppler vasospasm definition. So keeping those 4 definitions in mind, Frontera in a very elegant study, I enjoyed reading it, did an analysis on 580 patients that they had, and he applied those 4 definitions on them, and then studied each definition to various hospital complications, quality of life, cognitive dysfunction, death or severe disability at 3 months, and he adjusted for the common covariants in subarachnoid hemorrhage. So he found that symptomatic vasospasm, based on the definition that I told you in the previous slide, occurred in 16%. And DCI or delayed cerebral ischemia happened in 21%. And the last two radiological definition, which is angiographic and TCD, happened in 31 and 45 respectively, which I am really surprised, because when you read in the literature, you will find it far common than this. But this is what they found in the literature and on their patients when they apply the definitions that I mentioned in the literature. They reached a conclusion, and I agree 100% with that, that angiographic and TCD vasospasm were not related to any aspect of clinical outcome. The outcomes that we mentioned, cognitive, hospital stay, neurological outcome, death in 3 months. Both symptomatic vasospasm and delayed cerebral ischemia were related to reduced instrumental activities of daily living, cognitive impairment, and poor quality of life, which is really, these are the important things that you want to know when you apply a definition on a bad disease like this. However, delayed cerebral ischemia was better and was associated with death and severe disability in 3 months when compared to symptomatic vasospasm. So it has a further outcome implication, if I may say, on vasospasm definition. So keeping those definitions in mind, and once those are applied on a 500 patients, more than 500 patients, the bottom line is delayed cerebral ischemia is more clinically meaningful definition than either symptomatic deterioration alone or the radiological definitions, either angiographically or transcranial Dopplers. Why we are saying that? Because you're going to see nowadays in the new literature in vasospasm, there's a shift from labeling or naming vasospasm in the papers to delayed cerebral ischemia or delayed neurological deterioration, delayed ischemic neurological deterioration, which is DIND. That's the other definition that you're going to see. So literature is shifting toward DCI instead of vasospasm or symptomatic vasospasm. So for the residents in the audience, this is more elegant to use, and it shows that you understand what's going on in the literature. So this is the definition. Now we all agree that DCI is better, so we're going to use it. Okay. Now we'll try to understand the pathophysiology, and the literature is full of all the theories that you can read. When you start reading from this 70s, 80s literature, you will find every 10 years there is a wave of theories that happened, and then everybody gets excited, gets studied, and then fades away, and then another theory, everybody gets excited, studied, fades away. So you have cycles, and then someone decides, oh, we should study back this theory with new modalities. So you will see theories going back and forth, trying to explain why vasospasm is happening. Until now, we don't have an explanation, really, for why this is happening in patient X, not patient Y, although the same had subarachnoid aneurysmal subarachnoid hemorrhages. So let's understand first what happens. So there are many factors that contributes to brain injury in subarachnoid hemorrhage. I like this table because after the aneurysm rupture, these factors can be divided into two: acute and chronic, neurological, systemic. So you have an acute neurological factor, acute systemic factor, chronic neurological, chronic systemic factor. There are some people will add subacute in the middle. All these combined can lead eventually to neuronal death and brain injury if you don't tackle them. And you can see it's a big table with a lot of factors. This is not inclusive. These are the most common ones. And you can see acute cerebral factors, early systemic factors, early brain injury. You can see vasospasm here in this big list. So we're talking about very bad manifestation or a very bad factor in brain injury and subarachnoid hemorrhage among many of these ones. It shows you how complex and dangerous is subarachnoid hemorrhage and the many factors that you need to consider when you assess a patient with vasospasm. So, keeping this table in mind, the precise pathogenesis, everybody agrees on this, the precise pathogenesis of vasospasm is still the subject of investigation. The acceptable theories that I think for the residents and for the sake of the exam that you can support right now with literature are two. The most common cited theory right nowadays over the last 10 years is the biphasic vasoconstriction theory. What do we mean by phasic? In the old days, they were saying, oh, it's overproduction of vasoconstrictors. And then they said, no, it's underproduction of vasodilators. Finally, they reached a conclusion, it's actually both. It's very distinct biphasic vasoconstriction. Overproduction of vasoconstrictors, notoriously endothelin 1. Just remember this because it's going to come in the studies that I'm going to explain. And underproduction of vasodilators, and the most common one that everybody's talking about is nitric oxide. So that's why it's biphasic. And then the theory that still holds ground over the last 30, 40 years is inflammatory remodeling of the blood vessel, which leads to narrowing down the road. So after reading about this, I think if you do an autopsy, and it's been shown, if you do an autopsy, an acute phase, subacute phase, chronic phase, on the long run, on subarachnoid hemorrhage patients, you will find inflammatory changes in the wall of the blood vessels, either a little bit or massive remodeling, leading to chronic narrowing. So it's been said that inflammation is the culprit for chronic remodeling more than acute, which is true sometimes. And the authors nowadays in the new chapters talking about vasospasm review articles, they're saying, oh, it's a combined process, citing these two common theories and other abandoned theories. So for the residents, it's biphasic vasoconstriction, overproduction of vasoconstrictors, underproduction of vasodilators, and inflammatory remodeling. Where do we put these theories in the big picture of neuronal damage? You can see it here in the left upper corner. Increase or overexpression of vasoconstrictors and underproduction of vasodilators will lead to large vessel vasospasm, which is the thing that we will detect on the radiology picture, on the radiology images. And note, and this is very important note, vasospasm is a non-specific phenomena. People used to think that, oh, when you have a lot of blood on the scan, the area most likely going to be affected is the area where the blood is. That's partially true, but you can have vasospasm away from the blood clot. It could be on the other hemisphere, and it could happen on the microcirculation. So you can have a patient deteriorating from vasospasm, and his TCDs will be within the normal range. Or you do a CTA and it shows mild vasospasm, not explaining why he's deteriorating. Think about microcirculation. So this is off note. So if we put those theories that we spoke about, coupled with neuroinflammation, this will lead to the vasospasm, which is only one arm in the big picture that leads to necrosis and neuronal cell death. You have the inflammation will lead to blood-brain barrier dysfunction, which leads to brain edema. Putting this with other factors like microthrombosis and microvascular dysfunction will lead to hypoperfusion, which will aggravate the The vasospasm also increased the metabolic demand because subarachnoid hemorrhage patients are in a hypermetabolic status, cortical spreading depolarization associated with ionic dysfunction. All of these, if you put them together, they will lead, it's going to be multiple hits, all pointing toward neuronal death. Adding to an external factors that will aggravate it, which is smoking, diabetes, and other systemic complications from the parent disease, which is subarachnoid hemorrhage, this will lead to DCI. So we see the bigger picture now. DCI is the end manifestation or the end picture of a huge pathophysiological problem or pathophysiological cascades ongoing. All of this will lead to poor outcome. So understanding this, you can see why people are working on trying to develop medications or preventative measures, tackling every point of these that we spoke about. Okay, now let's shift gears to trying to unify our approach to the diagnosis, because you will see in the literature, some people are sticking to TCD diagnosis, some people sticking to angiographic diagnosis, some people are sticking to clinical diagnosis. So we will go through that. After the first slide, we all agreed on the definition, and we saw that DCI is a clinical diagnosis plus radiological confirmation. So you have to have a clinical deterioration. So it's a detectable neurological worsening or a deficit attributed to ischemic territory. So it's an MCA, ACA, or any other ischemic territory, paresis, aphasia, apolia, you name it, decreased level of consciousness, after ruling out all other causes of deterioration. And again, I'm citing this table because it summarizes all other potential causes that can lead to deterioration or secondary deterioration during subarachnoid hemorrhage. So whenever you approach a patient, and this is to my fellow residents, whenever you approach a patient and you're called for a new deficit, usually in the window of 3 to 21 days, think about vasospasm. Yes, you're right, but you have to rule out other things: seizures, rebleeding, cerebral edema, hydrocephalus, ICP. These are some of the neurological and systemic. You have to rule out fever, infection, inflammatory. So while you're going on the way to see the patients, run this list. So you can examine the patient, ask for blood tests, because vasospasm is the diagnosis of exclusion. So you have to exclude all other potentially treatable causes, okay? We all agreed on that, okay? So you have to have a neurological deficit that you attribute to a territory, coupled with radiological evidence. So increased velocity in TCD, and there are many cutoffs, people citing more than 120 with the neurological, with a Lingard ratio, or 200 as an absolute value, or you have other fancy tools that they don't think they are applicable really in the real clinical life, all in research, which is pathological reduction in cerebral blood flow, either measured by perfusion, SPECT, xenon, or thermal flowmetry, or detected by MRI when you see infarction, or using NIRS or any microdialysis or any other tool that can measure ischemic products in the brain, or by vascular imaging. You do an angio or a CTA and you see vasospasm. Again, it's very important to have a clinical diagnosis. I think it's shame on me or shame on you if you have to diagnose vasospasm based on and initiate treatment only based on radiological worsening. Not detecting clinical deterioration is sometimes dangerous, because you're going to over-treat radiological vasospasm because it can reach up to 70% in the literature. Okay, so bottom line in this point, the message that I want to send, it's clinical and clinical diagnosis. You have to justify why you're thinking about vasospasm, and then you confirm with radiology. Okay. Then we have the dilemma: if you have a patient with high-grade subarachnoid hemorrhage,
Dr. Abdurrahman. Dr. Abdurrahman.
Secondary causes, and based on that, you go from there. Again, you can use ancillary tools that can help you. You can use whatever you want. It's a big battery of supportive tools, I call them. You can name it, from oximeters to NIRS, EEG, anything that you can measure anything that can measure the brain function, either by metabolites or by electrophysiology or by radiology. Okay, so you can add these as a complementary to your assessment, and you have to have a gut feeling. It's also your gut feeling, and we know the higher the grade of the patient, clinical grade and radiological grade, the higher the chance of vasospasm. Okay. Let me take a break for 2 minutes here, and if you have any questions on the previous slides, let me just check the chat.
So far, Dr. Abdurrahman, we don't have a question, but if we can summarize the diagnostic criteria for confirming an angiogram is clinical and radiological. It's not depending only on radiological imaging.
Correct. So one thing to the residents, when I approach a patient with subarachnoid hemorrhage who's comatose, which is this is really the problem. If the patient is talking and walking, the deficit is going to be clear. If you have a patient who's comatose, I think territorial. When I come to the patient, I think about all the vascular territories. So think about the ACAs, think about the MCAs, think about the PCAs, think about the carotid itself, think about the posterior circulation. What deficits could give you when this happens? If the patient having decreased level of consciousness, oh, is it bilateral anterior cerebral artery or unilateral anterior cerebral artery, or is it posterior circulation, or it's hemispheric? So that's my thought process when I approach a patient. So you have to think territorial when you examine the patient. You don't need to do a spinal exam, segmental, so on and so forth. No, think as a territory, as an arterial territory when you approach subarachnoid hemorrhage patients, ruling out vasospasm. So that's the way I do it, and I think this is a very fast screening to do. Yasser here asked about the role of EEG. It's complementary. People are using it right now to detect mainly subclinical seizures, which is very difficult because it's subclinical, and you have to rule it out before you say this is vasospasm. And they use it for also to detect functionality of the brain. If you have one hemisphere or one lead more having hypoactivities or changing in its wave, this means that this area starts to be affected. And there are some literature supporting the use of continuous EEG in detecting vasospasm. But again, nothing will replace a good clinical exam. Again and again, nothing will replace a good clinical exam.
There is a question about what's if we treat a vasospasm and offer treating the vasospasm. Is there any problem with that, or any complication can happen to from treating vasospasm?
That's an excellent question. We're going to come to that in the management in the next few slides.
So we can go to the management and we go back to the
sure.
If you like.
Okay. Now let me scare you a little bit and move on from neurosurgery, neuro-ICU to physics. Okay, we're gonna talk a little bit about quantum mechanics. It's frozen here. Okay. Who knows what is this law? Take your time. This is the man who wrote this formula. This formula dedicates basically what we do in vascular. When you deal with vascular or any blood vessel in the body, and the brain is not an exclusion. All stroke neurologists, vascular neurosurgeon, interventional neuroradiologists, neurointensivists, Basically, my life is around this formula. To keep it simple, you're trying to make sure that enough blood is coming to the neurons. How can we do that? This formula explains the relationship of laminar flow in a tube. What will happen of a laminar flow in a tube? If we accept that the tube is the blood vessel and the laminar fluid is the blood, with a caveat, of course, then we can apply this equation on it. Whatever you do gonna affect the flow. So flow rate equals a constant multiplied by the pressure multiplied by the radius to the power of 4. Pay attention to the power of 4, okay? Divided by 8, multiplied by fluid viscosity, multiplied by the length of the tube. So we have 4 factors that we can alter as a physician to increase the flow to the brain, or increase the blood flow to the brain. Now we are dealing with blood flow to the brain. So either you fix the pressure, which is P, or you play with the radius, or you play with the viscosity, or you change the length of the tube. So we cannot do that. We cannot change the blood vessel, really. So we have only really 3 factors. And these are whatever we do in vascular, neurosurgery, or interventional, or ICU, come really down to those 3 factors. Okay, manipulating the pressure, manipulating viscosity, manipulating the radius. Until, hopefully, in my lifetime and your lifetime, we are able to develop neuroprotective agent. If we can develop these and they are successful, then this equation is obsolete. Inshallah, I'm hoping that. So for now, my life, your life is around this equation. So let's see the implications of this. This is the Poisson law. I don't know if someone got it.
Yeah, there is one for attendee, answer it.
Muhammad. Okay. Muhammad, if you didn't get it from here, I'll buy you a coffee. Okay? So let's see what happens if we play with those factors one by one. Okay? Pay attention to this. This is very important. If we have a constant flow in the tube, in the blood vessel, let's say 100 cubic centimeter per second. Okay? If you double the length, you're gonna cut it down to half. Just remember, the length is in the denominator. If you double the length, you're gonna affect the flow. You have a longer distance to travel. Makes sense now. If you double the viscosity, you make it more viscous, it will take more time to travel. So if you double the viscosity, you will cut the flow to half. If you double the pressure, on the other hand, because it's up there, you will double the flow. So if you double the pressure, you double the flow. If you double the radius, look what happened. Because it's to the power of 4, okay? So if you want to double the flow, like you double the pressure, you double the flow. If you want to double the flow by using the radius, you only need to increase it by 20%. So you can't see the magnitude of the radius change. And that's gonna be my key to convince you to use Merlinon, okay? So why I'm investing time and trying to convince you with this equation, excuse me, because all the treatments that we're gonna use in the next slides are playing around these factors. Make sense now? This is a busy slide, but don't pay attention, please, to it. If you wanna increase the pressure by 5-fold, let's say that a dog is chasing you and you need it instantaneously to increase the blood pressure to the brain by 5 folds. Do you really need to pump up the systolic to 600 from 120? Doesn't make sense. It's not applicable. You just need to increase the radius by 50%. Just 1.5 dilatation in the blood vessels, in the vascular in the vascular bed that you have in your brain and your body, and you will have 5 folds increase in the blood pressure, applying that the pump is working sufficiently. So you can see the power of manipulating the radius of any tube. Okay. All right. Enough for the physics. Let's go back to medicine. Okay. So every effort should be made to prevent it in the first place. But how can we do that? We don't have medications. We don't have anything to predict it very well. It's only screening that we're doing, screening clinical exams, screening this, screening that, do radiology, all in trying to anticipate when it's going to happen. You can fight the climate that can lead to it. How can we do that? So make sure that the environment is not suitable for vasospasm. Okay, so what shall we do? Some general measures that we do. Treat the culprit, treat the one that led to bleeding, repair the aneurysm. Okay, maintain euvolemia. So I'm trying to correct some of the old habits that we have. I'm still hearing, sadly, people are citing triple H. Don't use that. Okay, I'm coming to that. So maintain euvolemia, prevent anemia. Again, I'm fighting the triple H. Okay. You'll see it floating in the literature, citing different cutoffs of hemoglobin, but I think the best one is less than 9. Transfused less than 9. Prevent hyponatremia, obviously. Maintain normal to high blood pressure. This is just prevention. Vasospasm did not happen. Good ventilation, good oxygenation. Fight high ICP because you don't want it to affect the cerebral perfusion pressure. And then give the only medication that we have, which is nimodipine. Does it prevent vasospasm? Yes or no? Let's see. Yes or no? Does it prevent vasospasm? Okay.
Personally, I don't think so.
Okay. No. Good. Fantastic. Great. Very happy. Very pleased. It does not prevent vasospasm. Okay. It is a neuroprotector. It works on a cellular level. There are many theories, but the most acceptable ones, it reduces the chances of a neuronal death by preventing apoptosis or decreasing the chances of apoptosis by many mechanisms. One of them is preventing calcium influx. That's why it's a calcium channel blocker. Okay. And then one of the theories is that the blood is outside the blood vessel, not inside the blood vessel. So whenever you have a blood outside the blood vessel on the surface, it's very irritant. So why don't we clear it? So you're going to see a literature about augmentation of subarachnoid hemorrhage clot clearance. People did a lot of things, okay? Clot lysis, cisternal wash, lamina terminalis fenestration, EVDs with the washing in and out, insertion of fibrinolysis, TPA, urokinase, you name it, head shaking, combined treatment. And by the way, this is the neuro shaker. Put the head of the patient here on a pillow and you fine tune the timing, how much you want it to shake the patient's head. It's actually named the neuro shaker apparatus by Mizuho in Japan. There's a paper claiming that it works. And then lumbar drainage. There are 2 big trials happened. The LUMAS trial in 2012 and ongoing the early drain trial with unfortunately questionable benefits. So it makes you feel good. Do it if you can. It can hopefully help. But the level of evidence is very weak. Unfortunately, it's only retrospective and historical data. Only lumbar drainage has phase 3 trials ongoing. Now, let's see the investigational preventative treatments that we tried over the last 3-4 decades. People tried prophylactic balloon angioplasty. It did not work. It failed miserably on a phase 2 trial. It was actually harmful. Don't do it. Okay, we're talking about prophylaxis here. Vasospasm did not happen. People tried intra-aortic balloon pump, and the concept here is you're trying to augment the flow to the brain more than the rest of the body. It reaches up to phase 3 trials, and then it fails. There's no significant benefit. And then the one that was very hot during my residency, magnesium and statins, both failed on a phase 3 trials. Free radical scavengers had their shot also, failed in a phase 3 trial. Remember our friend, the endothelin, the potent vasoconstrictor? It was tested on an antagonist. They use antagonists in conscious 1, 2, 3 trials. Did not work. Intraventricular nimodipine. Why do you want to give it orally? Just give it directly in a good concentration. It is safe. The Newton trial came out a few years ago. Effective, questionable. Phase 3 is ongoing. So it might come out anytime next year or the year after. So pay attention to my fellow residents here. The Newton 3 trial. Other intraventricular drugs like milrinone, nicardipine, marginal benefits, doesn't have good evidence. It's only shown some benefit in retrospective studies. So you can see how disappointing is the preventative measures that we're trying, or the preventative medications that we're trying. Okay, it happened now. The patient developed vasospasm. What shall we do? What shall we do about it? Every time I approach a patient with a vasospasm, I go back to the general measures. Make sure that the patient is hydrated, make sure that his blood pressure on the high side, make sure that he is on nimodipine, make sure that his ICP is not high. So you rule out all the confounding factors that we spoke about. Maybe he's deteriorating because he has seizure or something like that, okay? Once you exclude all this, because the rescue treatments are interventions, they have potential complications. So you have to justify using them, okay? The way I see it for rescue treatments, 3 ways. Either systemic intervention, endovascular intervention, or intrathecal intervention. We'll go one by one. So, the famous triple H, finally. It does not work. Do not use it. Do not mention it. It's not recommended. It's against good practice. Why? When people compared hypervolemia to euvolemia to maintain just normal volume status, it did not prevent DCI, which is the definition that we all agreed upon that we're going to use. It did not prevent delayed cerebral ischemia. On the contrary, it was harmful. It increased the risk of pulmonary edema. It increased the risk of myocardial ischemia, and it increases the risk of cerebral edema. So you're hitting the most 3 important organs that you're trying to save here. So hypervolemia is bad. So that's the first H. The second H is hemodilution. People in the old days, especially in the 80s and the 90s, they were driving the hemoglobin down to reduce the viscosity. Remember in the Boiseuil law that we said, reduce the viscosity to increase the flow? It sounds logical, but you really don't want to reduce the blood or the oxygen carrying capacity of the blood. When you dilute the blood, you reduce the oxygen delivery. And then overall, you decrease the oxygen supply to the brain. So the reasonable target hemoglobin here is above 9. Okay, so this is the second H. It's harmful. The third H, so I call it single H therapy, not triple H. The only one that's proven actually it's efficient and it works is hypertension, induced hypertension. It's more effective. Why? Because you just increase the cerebral blood flow. And it's more effective than the other 2 H combined, actually. But please pay attention. This is very important to the residents. The autoregulation curve, remember it? Up, flat, and up. The autoregulation, the part that is flat, that the brain is controlling, is gone here in subarachnoid hemorrhage. It's like the model of acute traumatic brain injury. The autoregulation curve is linear here. So an increase in the blood pressure will have a significant increase in the cerebral blood flow. A decrease in the blood pressure will have a significant decrease in the blood flow. So pay attention to the blood pressure. Blood pressure manipulation here is very important in subarachnoid hemorrhage patients. That's why it works when we push them up on the higher side. Just 2 slides left here, 2 or 3 slides here. So bottom line is, induced hypertension has been shown to reverse symptoms of vasospasm up to 2/3 of the patient. It's a powerful tool here. Use phenylephrine and norepinephrine. It shows that it's more predictable and more beneficial than other agents. Okay. Let me go to the second line. So the first line of treatment, don't do triple H. Maintain euvolemia, increase the blood pressure. Did not work. This is from me. This is my second tier, which is IV milrinone. Milrinone is a phosphodiesterase inhibitor used to treat vasospasm, intraarterial, intravenous, intrathecal. You can see people are trying, it works. So they're trying to use it everywhere, okay? We follow at King Fahd Medical City, we follow the Montreal Neurological Hospital protocol, which is basically you give a bolus, 0.1 milligram per kg, and then you follow it with 0.75 mics per kg per minute. After optimizing the other conditions that we spoke about. If it doesn't work after 30 minutes, you increase the infusion, okay? It was found to be helpful in reducing DCI, which is, we all agree that this is the most important thing we're looking after. And the other important thing is it reduces the chances of you going to angio for angioplasty. In my fellowship, I took care of 80 patients, subarachnoid hemorrhage over 2-year period. And we only went to the angio suite twice because we were going up on the milrinone. We were actually did not stop at 1.25. We went up to higher doses as the patient tolerates, but it works marvelously. So that's why I don't have an equipoise on using milrinone. So bottom line here, intravenous milrinone should be, I said maybe, but it should be considered a second line rescue therapy here, intravenous, okay? Now, we spoke about the systemic use. Now we're going to go quickly to the endovascular reversal for vasospasm. After 2 hours, 1 to 2 hours, if your previous measures does not work, you have to worry. You have to call for an angio. It's a code stroke. He is going to stroke out if you don't reverse it, okay? So take him to the angio. We have either mechanical angioplasty, we use balloons, stents, whatever, or chemical angioplasty. We use a long list of drugs. I personally prefer verapamil and nitroglycerin because the patient is already on milrinone. So we have 3 agents, 3 vasodilators, okay? Where does it come, the rationale to go to the angio immediately for angioplasty? Don't wait. 2 studies. The Philadelphia group showed actually if you take the patient within 2 hours of the deficit after failed medical management, it showed that they had a better outcome than waiting more than 2 hours. So that's the 2 hours rationale here. Someone actually stretched it to 1 day. Patient is having a deficit or a drift for 1 day. How can you leave that? Someone did that actually, and they looked at their data. Even if you intervene before 1 day, within 24 hours, the chances of a preferable outcome is far better than after 1 day. So please, if your patient does not respond to the measures that we said, activate code stroke, take him to the angio suite. It's a code stroke, okay? Because they're gonna stroke out and you'll have a worst outcome. And then we reached the third route. So we said systemic, endovascular, and intrathecal. People used a lot of medications. You will see floating right now in the literature, milrinone again. Sodium nitroprusside has been evaluated in small studies. They showed marginal benefits, but a lot of complications for that. There is an ongoing trial in Japan right now for intrathecal milrinone. I'm hoping to see some results on that. So, in conclusion, it's a significant DCI. Let's agree on using DCI. Delayed cerebral ischemia is a problem. It's a huge problem for us in subarachnoid hemorrhage management, and it causes significant morbidity and mortality. Take it very serious. Don't take it lightly, okay? Because it's unpredictable. You don't know which patient is going to be affected, but you have some signs before the ones that we spoke about, okay? It is a multifactorial process. You cannot pinpoint one pathophysiology as we saw previously, and it's still incompletely understood. There is no single algorithm that you can say I'm going to use and khalas, will be the treatment. It's not like sepsis. You have bundles for it, or ARDS in ICU. You have bundles for it. Subarachnoid hemorrhage depends really on you, on your understanding of the disease, and on the tools and the utilities that you're going to use to detect and treat. So really understand this disease so you can treat it in the future if you face it. You have to have high index of suspicion. I cannot emphasize on this. If the patient does not look right for you when you're around, please, please, please put vasospasm on the differential diagnosis and a good clinical exam. So high index of suspicion, good clinical exam, and pathological confirmation may help in early detection and stroke prevention. I hope that was useful. Open for questions.
Thank you very much, Dr. Abdurrahman. We will open the floor for the questions. You can type it in the chat. It will be easier for us to go through it. Dr. Abdurrahman, we encounter some different approaches to vasospasm in a phase that we diagnose the patient with subarachnoid hemorrhage. Some consultants, they don't like to start nimodipine and till there is a clinical and radiological manifestation of vasospasm.
So milrinone, yes, you don't need to start it prophylactically. It's a rescue treatment. Nimodipine, no, it's a preventative. You have to give it. If you have it in your hospital, you have to give it, okay? The only problem with nimodipine, it's a potent antihypertensive. So you have to balance it. Remember that hypertension, normotension / hypertension is good. That's what we want. On the other hand, you don't want to keep the benefit of nimodipine from your patient. It's an excellent neuroprotective with proven studies again and again that it affects the outcome. So yes, for nimodipine, give it if you can. Milrinone, it's a rescue treatment.
Okay. So we have questions about the hematocrit level. What is the ideal goal for hematocrit level in subarachnoid patients?
So the problem with hematocrit, as you may all know, it's fluctuant. It depends on when did you take it, the time of the day. Is the patient just got a bolus of fluid? Is he dehydrated or not? I don't personally follow or recommend using hematocrit. Use hemoglobin and trend it throughout the days, because the carrying capacity really is in the hemoglobin itself, the oxygen carrying capacity. So I use more than 8 or more than 9. If the patient has high risk of vasospasm, I even go more than 10. I transfuse them, keep them above 10. Okay. But the literature here, and you will find it in the recommendation, especially in the British guidelines, you'll find it more than 9.
Okay. I have a couple of questions about the transcranial Doppler, the value, and is it significant to do it like a routine evaluation for the patient as anticipating any?
Yeah, that's a great question. If you can, it is embedded now in the protocols. You will find people screening every 48 hours, looking for this, especially in high-grade subarachnoid hemorrhage. There is a push actually to use continuous TCDs. There are small probes that you put on the patient, like with the EEG, a full bundle they call it, and it will have continuous TCD reading, and you will see the velocity as it goes up. It's actually fun to see, but it's very exhausting because you have a lot of information to deal with. So I personally use TCDs as a screening tool, and sometimes to guide treatment. If I give, for example, milrinone and see the velocity goes down and the patient wakes up, this is a confirmatory test. So as a diagnostic tool, yes, but with a good clinical exam again, and as a screening measure, yes.
So since you mentioned the clinical exam, we have a couple of questions about the patient is comatose and patient intubated comatose. How can we evaluate him clinically? What is your parameters to evaluate the patient clinically to get a clue where should we go with the management?
So you have to have a high index of suspicion. Again, if you come and examine the patient, let's say day 5, and his GCS was 6 and became 4, or 5 became 3, You have to rule out other secondary causes. The long list that we spoke about. They have all the reasons to have seizures, electrolyte disturbances, hydrocephalus. So you have to check out the list. And then this should not take you more than 1 hour. All the the list that we saw that you need to screen for, you should not take more than 1 hour to rule out. Send all the labs stat, examine the patient. If it doesn't feel right or it doesn't make sense to you, take him for a confirmatory test. Do a TCD at bedside. Take him for a CT scan or a CT angio to confirm your diagnosis, because it will have consequences. If you want to use any of the rescue treatment, it will have consequences of that. So again, good clinical exam, rule out the list, that the confounders that I spoke about, and then go for radiology after.
So I have many questions about the blood pressure, but I will remodel the questions to one question. What is your target of blood pressure in subarachnoid hemorrhage, pre and post aneurysmal management, or post securing the aneurysm?
So if you read in the guidelines, it's written that before the securing the aneurysm, you should make it less than 140. There's some studies supporting that. After securing the aneurysm, I let them auto-regulate. So you will see actually the blood pressure climbing up in the patient on their own. And sometimes it will give you a clue that there is something cooking the day 3, day 4. You will see the auto-regulation kicks in. You will see them going into the 150s, 160s on their own, because the blood vessels are getting tighter. So the body is trying to compensate for that. I let them go up to 200. I don't have a problem with that. This is on their own. I don't push them, okay? If they develop vasospasm, on the other hand, I am very aggressive in pushing them. So I push them above 140 all the time. I usually stop pushing them at 190. I don't want them to go into hypertensive crisis or end organ failure. It's going to affect the eye, the kidney, especially if you use it on long day for few days, few hours until you reverse the deficit. That's what I do. Okay. So that's to answer your question. The cutoff seems to be in the literature 140, less than 140 until you secure the aneurysm, above 140 once you secure the aneurysm.
Okay, for our junior colleagues, when you will see the vasospasm, you will receive a patient with subarachnoid hemorrhage diagnosed just a couple of hours of arrived to the department. When you will expect that the patient within the period that he's peaking of for vasospasm?
There is one entity that I don't want to mention, not to confuse the audience. There is an emerging definition of ultra-early vasospasm, which is a completely different than the DCI, or the delayed cerebral ischemia, or the vasospasm that we're talking about. So the classic vasospasm that we are all afraid of is commonly said that it starts at day 3, peaks at day 7, 10, then start to dwindle down until it ends at 18 to 21. So that's the range, day 3 to day 21. The ultra early vasospasm is when the aneurysm ruptures immediately. So this is a protective mechanism. This is a protective vasospasm, trying to reduce the flow to the parent vessel of the aneurysm. And we see that when we have an intraop rupture. In the angio suite, when I have an intraop rupture, if I shoot, even under the microscope, when you have an intraop rupture, if the field is cleaned up, you will see the blood vessel also constricted. So this is the ultra early vasospasm. Like manipulation vasospasm when you touch the blood vessel. So this is a completely different entity. The one that we're talking about that happens between day 3 and 21. So that's the time period that I'm talking about. There's one interesting question here by one of the boys. He was asking about the role of albumin.
Yes, I was about to ask you about the albumin and cortical.
Yeah. So albumin and corticosteroids. Do not use steroids in subarachnoid hemorrhage. Please, please, please don't use it. I use it only for one thing. If you have a devastating meningism that is compromising the patient care, they're having very bad headaches from that or very bad neck pain because blood is very irritant to the meninges. At this point, yes, use that as an anti-inflammatory and a painkiller. It's very powerful. I use it as a tier 3 after using Tylenol or acetaminophen, non-steroidals. If they don't work, I go to steroids. Short course, 1 to 2 days. It works great. Don't use it to lower ICP. It does not work. It is actually harmful because the majority of them, they have long ICU stays. They will develop infections. It's going to affect their lungs. Do not use steroids on a long run for subarachnoid hemorrhage patients. Use it for pain. It's good. It's a very powerful pain medication and to help with the meningism. So that's what I see it, okay? So this is the steroids. The albumin, it used to be also a hot topic in the Triple H era. So it's an intravascular expander. So it keeps the fluid inside the blood vessel. So it will reduce the viscosity. So it will drive down the hemoglobin. And it will increase the intravascular compartment and will drive the fluid to the blood vessel. So people studied it with contradicting evidence. So some people will say, "Oh, it will work greatly as an agent." I think if it works as a surrogate because it will increase the blood pressure indirectly. So that's how it works. But it has a lot of complications as the blood vessels are leaky. If you remember, we said the blood-brain barrier is disrupted here. So if it leaks, it will actually aggravate brain edema. So if you want to use it, you can use it once as a volume expander. If you want to push the blood pressure up for an acute deterioration, don't use it chronically. Chronically, on the long run, it's actually harmful. It's like mannitol when you lose it for a longer period.
Thank you very much.
One more question, or that's it?
You are the boss. I have so many questions. So
one last question. So I think it's important. How long can you or should you keep the patient on milrinone? This is very important, actually, especially for the residents rotates here at the National Neuroscience Institute. You will see at least 2 to 3 patients on milrinone at any given minute when you go to the neuro ICU. So it's a medication with a half-life of 6 to 8 hours. So when you stop it now, you're only going to see its effect after 4 to 6 to 8 hours. So don't stop it in the afternoon and leave because the effect is going to happen at night. Nobody will pay attention to it. So that's number one. So understand the half-life. It's very important. And we don't stop it abruptly. So if they are on one mic per kg per minute, you don't stop it like that. We wean it. There is no literature supporting how you do it, but we follow the Montreal Neurological Institute protocol. So we go by increments of 0.25 or 0.5 if you're in a rush, either to escalate or de-escalate. So if you're on 0.75 mics, which is the standard dose, you want to go up, the patient is still weak, you go up by increments of 0.25 or 0.5. And you wait, okay? If you want to wean him off, I usually wean off by 0.25 per day. So the classic dose, the 0.75, it takes me 2 to 3 days to take off. So I stop it in the morning, early in the morning, and then I come in the afternoon and examine them. If their neurological status is stable, then tomorrow morning, I'll drop it even more until they're off, okay? So 2 important things. Do not stop it abruptly. Wean it to stop it. Because if they deteriorate while you're weaning, you know that the sweet spot is the dose that they deteriorated on. So you put them back on. And usually I keep them on for 2 to 3 days, and then I re-challenge them again. I make sure that they are euvolemic, give them blood if they need, and so on and so forth. So it's a slow process. You need to do it. You have to respect the disease. Don't do it too fast because I've seen miserable deteriorations and strokes because people stopped on a very high doses of milrinone and they send them out to the floor because the patient looks great, GCS 15, no neurological deficit from hemiparesis or 2/5 in the power 4 or 5 days ago.
Okay.
I think that's enough for tonight.
One last point, Doctor.
Sure.
Transfusion to maintain the hemoglobin, it will affect the viscosity of the blood.
Sure.
So how can we balance between those two?
So again, you have to the most important thing is oxygen delivery. So there is no sweet spot. You cannot say I'm going to transfuse up to, let's say, 14 grams or 14 milligrams per deciliters. Don't go down, just go up. I keep them around 10 to 11. That's the sweet spot. Don't use anemia anymore. It's harmful. Don't use it. It's bad. Okay. Stick to a cutoff that you believe in based on your reading. Above 8, above 9 is okay. Okay. So if you give them 2 units, they will stay around 10 or 11.
Okay. Thank you very much, Dr. Abdurrahman. Really an important topic we encountered in a daily practice, especially in the tertiary center where we receive a lot of subarachnoid hemorrhage. For the audience, I would like to just announce the continuity of our webinars. It will be announced in the WhatsApp group and better in Telegram channel for the SANS Academy. For the previous webinars, you can find it in our YouTube channel. Almost all webinars are uploaded, and remaining only 3 or 4 webinars will be uploaded soon. Thank you very much, Dr. Abdurrahman, and for the audience for this great time.
Thank you very much. شكرا لكم يا شباب. السلام عليكم.